I'd love to hear your questions, but particularly I'm passionate about this rebranding of placebo thing. That's my favourite, Sarah. But I'll answer any question.
So do we have any questions in the room? Awesome.
Everyone else is asleep, that's right.
Thank you. That was very enjoyable for me. How do you reconcile, or maybe suggest that some of us reconcile Sandy Hilton's phrase, stealing self-efficacy, with giving the patient what he or she expects will help the most?
Yeah, and that I really appreciate, because that is often a point of discussion here, because I think there's a couple of different layers. One is, this is my opinion, is not to use an intervention I know might be harmful, is not to include it. But if it's not going to cause harm for me to include what you want in with stuff I want, that could be okay. Particularly some of the time, the setting I work in, lots of people say, oh, I want a hot pack and some massage. So nothing wrong with that, but we're going to do that at the end if we get all these other things done. And so then I can kind of incorporate it in a conditioning way and say, you did everything to quota, you participated, your illness behaviours were a little bit different, everything went well, so we're going to finish with a hot pack and a massage. There's your tailwind. See you next time. And so, I think that there's certainly that element. The challenge becomes you have to also be dose specific with those conversations, because otherwise you can trap yourself in saying, okay, every time it's going to be this. So what we'll do is once or twice, or maybe 4 times, so set a limit around the provision of those things. Yeah, you're welcome. Yes, mate.
My question is, have you ever... Oh, wait, can we put the mic so the people online can hear?
Who is it?
Sorry. Sorry.
Have you ever had to bring in a family member at the same time and got better outcomes when you co-treated together with that family member?
Yeah, and so like I said, knowing that, so my setting is a pro bono care clinic. We have family members, caregivers that are just sitting around all the time. Now, everyone comes. Everybody comes, and people are in the waiting room or they come into the treatment room, and so we are deliberately incorporating people sometimes, like, okay, you guys are going to work together on this. This person's like your walking partner, some of those type of things. So I don't know if that's exactly what you meant, but that's how we might incorporate people that are part of the social family or biological family or support network for that person. Not always, but when they're there, definitely include them.
Hi, Mark. I've just got a question, a comment.
Oh, finally, someone I can understand.
Yeah,
okay.
yeah, just from across the Tasman. You made a comment around providing context and meaning, in a healing ritual. I just wonder, I think we can definitely provide context for our patients, but I wonder if meaning is something that is they attach to it rather than something that we can actually provide. We might be able to provide the conditions for it. I just wonder if you've got a comment about that.
No, I completely agree. Meaning is assigned by that person, but I think we're establishing the kind of milieu in which the meaning can go in a direction that we want, and we can help kind of frame that meaning for them. So, okay, as I'm doing these things, what that actually means to you, or the implications for you are whatever it is. That We went through that whole exam. We didn't find anything serious. There's no serious pathology. Things look good. You're neurologically intact. The only thing that's left is like a muscle issue, and that's really easy to kind of do exercise to help work with that. That you can put and surround meaning throughout your exam sort of thing. But you're right, they have to eventually kind of adopt that or internalize that. Man. Not yet.
So you brought up the trouble of, or the problem of rebranding placebo, and so I'd like to. I think about placebo very differently from how I used to, and when I am presenting continuing education classes, I try to reframe it for the people in my classes, and what I'm wondering is though, when you look at it as a rebranding problem, are you thinking of it in terms of rebranding it among professionals or more with lay people? And so I guess I'm trying to figure out like the thrust of your question.
Yeah, so the rebranding, that's some good insight. The rebranding is for professionals, because when we work with patients and in an open study at the end and say, okay, you got the placebo treatment, would you have that again? They say, oh yeah, that worked great. Right? We have Dr. Robinson right now, the psychologist, has a study where we're comparing bivericane to trivericane. Trivericane works a lot better, by the way. And people are happy, not happy. People are okay getting a treatment that is driven by placebo. The branding part for professionals, I think, is that if I say, I'm going to do a technique that I think has a significant part of its mechanism based on placebo, versus I'm going to do a technique that's actually going to harness your capacity to engage your own endogenous pain modulation in an egocentric sort of, I can use all that sort of stuff. I wanted to use ACE. I'm going to use manipulation plus ACE, which is the active cortical enhancement. Right, so something like that, I think, would make acceptability. Where all this started is giving a talk to a group of manual therapists and saying, a lot of the intervention's benefit can be driven or explained by placebo mechanisms. People hear when I say that, you're doing nothing. But that's not what I'm saying. What I'm saying is that whatever you're doing is engaging that person's ability to modulate their own physiology, which is different from saying you're doing nothing. You're doing a lot. You have to be really skilled to do this well. You can't just walk up to someone and crack their neck and hope that everything's going to be good. You have to learn all the skills that go on with that to build a context and build a ritual and build everything. So it's a highly skilled process and not nothing. So I think it's a provider, probably rebranding that needs to happen. That was a long answer to a short question, wasn't it?
Good question, it's a good answer. And then up here, okay, so we have up here Robert, and then we have, you finished early, so you get a lot more questions.
Oh, I did? Okay, all right. I'm thinking I'm banging on and boring everyone to sleep.
Thank you. Thank you for your presentation. You had talked earlier about an intervention buffet or treatment buffet, and wondering if in your research you had found a sweet spot of how many choices is too much.
No, that's a really cool thing, the thought experiment that we haven't studied when it becomes overwhelming, but there's lots of other work that we draw on about choice. 4 is the magic number, right? So if I give you 4 things to do, that's tolerable. If I give you less than 4, I didn't get enough. I give you more than 4, oh, there's no way, that's way too many. So it turns out 4 in other types of studies of choice is good. So we give 3 or 4 things. But we've never really looked at people's satisfaction with how many choices should I get to be satisfied, and then if I'm satisfied, does that then improve outcome? You know, so there's a couple of layers, but so we go with 4. If I'm feeling lazy, which is a lot of the time, maybe it's 3, sort of thing. Yeah.
All right, thank you. I wonder if you could help me with this. I'm having a discussion with a colleague. He's got a very solid science background. He can out-science me any day. And the discussion is, how does function relate to pain? And in response to one of my statements that moving is really good, he says, okay, so you don't need to know muscles and techniques, just generally rub over an area and the CNS will make you feel better. This is his response. And that's about the point that I stopped the conversation. But I'm curious how you'd reply.
I would respond to that with what we were talking about just a little bit earlier, is someone can't just walk up to you, rub the painful area and tell you to move on the street and get the benefit. The person getting rubbed, before I do, sorry. Not even sure where to go. The person getting rubbed has to believe that rubbing is going to make a difference. And I may believe some random person who comes up and says, here, sit down, I'm going to rub that and you'll feel better. But it's more likely that I'm going to believe someone who has more potential training or experience, however you want to frame that. Now, I'm not going to disagree that there's part of me that says, as long as I, the patient, believe in what you're doing, I will get a benefit. It may not be as much as if it's treated with a complex package of stuff, but it will change, right? So I think the response to your colleague would be, yeah, if an untrained person comes up and rubs a painful elbow and tells them to move, there will be a change, but it'll be very small. If we want to get a larger change, then we're going to need to do some other things, and to do those other things, you need experience or training to be able to provide the context, harness all those other things we're talking about, as well as potentially modify physiology with exercise. This placebo mechanism just magnifies effects. It's difficult to say that you can get a change in pure isolation. You have to have been conditioned to an actual effect at some point for a placebo to work by itself. I can't just rub like saline on your skin and say, okay, now this is going to work as a pain reliever, unless you've been conditioned to that somewhere else along the line. So these can't just happen by themselves.
We have a question online.
Yes, we have an online question here from Stephen. How do you explain to your patients what's happening when you do a joint manipulation?
Oh, well, the way I explain it, so this is for me, I say that whenever we do a high-speed manipulation technique to a joint, we're actually giving your nervous system a really big stimulus. And what we know pretty soundly is that causes all these changes in your spinal cord that we can measure. We inhibit some of the neural processes that magnify pain. We also might be changing how the joint moves, but that's probably not the primary effect. We're probably getting all these changes in how your spinal cord and brain are processing the painful movements. It'll reduce your pain for a little while, that we can actually move, exercise, change, whatever we've got to do. That's how I would explain it.
Was there a hand over here? Okay. There, and then there was just someone here. Yeah.
Hi, I'm still a student, and I'm just looking for a little more insight into the difference between utilizing the placebo effect and lying to the patient.
So the key here is that you can't just use the placebo effect. you can harness the placebo mechanism to magnify the effects of your treatment. And I encourage you never to lie to the patient. You know, when you're harnessing the placebo, that's why we were talking about the branding. We say, I'm going to do something that we know changes your neurophysiology. And if I present it to you in this way, we can actually get a much bigger effect, much bigger change in your neurophysiology. That's what we're doing. But if I say, we're going to do this technique and a lot of it works through placebo, you go, we're going to do this technique and we're actually going to really engage your own system's ability to modulate what is going on. So you're not lying, and you can't provide, I beg your pardon, you could provide placebo by itself, but it doesn't work very well. It can magnify effects and make the effects that you're getting bigger. Right? So you're not lying. Don't lie.
You mentioned the general expectation of recovery as being the biggest predictor of recovery. I wonder how we can do a better job, either on an individual level or in a cultural, societal level, of improving that expectation.
Yes, that's... Can I talk politics for a little bit? Right, because part of that, I had the opportunity to go in Florida to talking to a bunch of legislators about non-pharmacological management of pain and how, you know, if you get in to see someone from chiropractic, PT or acupuncturist, chances are your downstream utilization of opioids is reduced 60%, exposure to new prescriptions is only 20% in those patients. And the legislators going, why isn't this on the news? Well, because none of our associates, I know the PTs don't, I'm sure the Massage Therapy Association, the chiropractors might have enough, but it's public awareness, advertising. You can see maybe a Lyrica commercial before the news, but you're probably not going to see an ad saying non-pharmacological management for your spinal pain reduces exposure. So that's a funding, branding, lobbying. If you're not a member of your association, become a member of your association. And if you don't want to become a member, donate to your PAC so they can do these things. So that's one part. And having, you know, I grew up, and I don't know if you could tell, I grew up in a foreign country, and it's not foreign to some. Foreign to some. And so when I think about growing up in Australia, you would see stuff like go and see your physio for whatever. I was watching a rugby match on YouTube, and it's got one of the teams is sponsored by so-and-so physiotherapy. And so just that's back to that cultural thing. We probably don't do much of that. You don't see a lot of or conservative care in television and all those sort of things. So that's another long answer to a short question. But yeah.
Any other questions? Online, anything?
We
got one more online.
Says I'm over.
I know, but you're not. Sorry.
Otieno asks, are there studies showing patients that initially had good outcomes with placebo but then got worse over time?
Probably I need to clarify that, because the magnitude of benefit decreases over time. So you get the biggest response to a condition mechanism the very first time you get it, and then it decreases and it decreases, and then you have to recondition. You know, this has got some pretty profound implications in my mind for drug trials. If I can condition a response to morphine in someone, and after 2 days of pairing the conditioning stimulus to the morphine, on the third day I can just give the conditioning stimulus and they get a morphine response without the morphine. Even if that happens just for 1 day, I've cut their exposure to opioids by a third. And so I think this idea that responses decrease, so it's not worthwhile. In some contexts, if you can get a response and then recondition it, and get the response and recondition it, that could be okay. So I don't know if I interpreted the question properly, but I certainly answered a question. Just not the question.
All right, anyone else? Oh, we have here.
Where?
Hi, I'm curious about the curse of knowledge and whether or not you knowing so much about placebo affects...
Nothing works for me anymore. No, this is a great question, and a series of debates we have in education is that my power as a provider came because I believed very strongly in my capacity to do what Miss Joel taught me in PT school was the best way to manage spine pain. 30 years later, having studied mechanisms, I say, well, what Miss Joel told me in the 80s is not actually what happens. And so you're right that if part of this is predicated on my belief in what I'm doing, but the education system is saying there's no evidence to support the efficacy of this treatment in patients with spinal disorder, then the student is left with this thing saying, what do I do? What do I do? If half of it is placebo mechanism and nothing works for large groups of people, how do I move forward? And so what we try to do is provide context for students that while these, and I'm being manual therapy centric, but while these techniques may not work the way we originally posited, they still work for millions of people all the time, just not the way we thought they did. They work because you systematically apply knowledge in a way that builds trust and alliance, and you apply these skilled and protected activities to decrease threat. It just may look different depending on what you're doing as a provider, but everyone's got these consistent elements. So then you say, find a system you like doing, believe in would be really good if you can find that. And then practice it, because you have to practice it a lot. I have a colleague in Chile who studies systematic knowledge, and as you develop a systematic approach and systemized knowledge, your outcomes go up as a provider, right? Because now you're doing things the same way all the time in the same set of... There's something about doing these systematic things over and over that improve your capacity as a provider as well. So find something you like, hopefully believe in, and then practice it a lot. It's the best advice I have, which is pretty lame, but it's still the best advice I have.
Okay, we're going to let you stop answering questions now. And thank you very much.